Hi, I'm Jackie Meinhardt. So nice to meet you. This is.
I'm Candace Lichardi, psychiatrist here at Amen Clinic and associate medical director.
Thank you so much, everyone, for being here. We are so excited for everyone here in the room as well. Thank you for coming out on this beautiful night in Dallas, Texas. We are talking about post-COVID, the hidden aftermath, dysautonomia, inflammation, and the brain-body connection. I love this picture because the heart and the brain, I truly believe they are connected. Actually, there's more afferent response from the heart to the brain than there is from the brain to the heart. Do you know that?
I did not know that fun fact.
Isn't that interesting? I think it is very
And do we
interesting.
know the difference between afferent and efferent? So afferent is arriving and coming to you, and efferent is going out.
Mhm. Yeah.
I keep it simple.
And that's perfect, right?
So E for exit, A for arrive.
Look at you. I never thought about it that way.
That's how I got through med school.
Well, there you go. So
Everything was a memory trick.
right? So, but anyways, the brain and the heart are connected. And actually, some of the things that I like to say is that when we look at the brain and the heart, whatever happens in the heart, I say it happens in the brain first, right? So we can't look at mental health as just being a psychiatric condition. It is actually a pathophysiologic issue that we see with many conditions involving the immune system. So let's get started.
Okay.
So the objectives today are
What is post-COVID illness, which is a big lot of things. So we're not going to get into every detail, but specifically what we wanted to focus on in our appointment today, not appointment. I've been working all day and I just haven't even finished my notes. So dysautonomia and POTS, because there's been a lot of that going on lately. I've been seeing, I didn't even know what that was 5 years ago. And now I'm like, hey, I think we got a thing here. Go see a cardiologist. And so then also expanding into the roles of immune and inflammatory dysregulation, endothelial, which are the little lining cells, dysfunction, vascular injury, anxiety, and neuropsychiatric sequelae is our wheelhouse here, and then how it relates with SPECT imaging in post-COVID brain function and what we find.
in post-COVID syndrome, the defining points of post-COVID is really persistent symptoms after 12 weeks or 3 months after the acute infection. It is a multi-system body system and a multi-symptom illness involving not just the heart when we think of postural orthostatic tachycardia or POTS, but also the neurologic systems and also the immune system. We know that roughly 30% of people who experience COVID or SARS-CoV will experience some effect involving their vasculature. And again, I remind patients, we have blood vessels from head to toe and all the organs in between. It's not just the heart, it's also the brain. And then it overlaps. Oftentimes you'll hear these terms like chronic fatigue or fibromyalgia. Those are diagnoses of exclusion, meaning they've ruled everything else out and that's what they rule in.
So what happens in dysautonomia and POTS? What's going on?
So it's really a sympathetic overdrive, if you will, the sympathetic tone, I like to call it. The autonomic nervous system becomes dysregulated. And that is where you'll see abnormalities or aberrations in the heart rate, the blood pressure, and the temperature instability. That's a big one. And a lot of people don't realize that temperature is actually controlled by the brain, right? Which is so fascinating. People think, oh, I'm cold. Well, it's really the brain function. But postural orthostatic tachycardia is when there is a change in the blood pressure and the heart rate within 10 minutes of standing. So we take a blood pressure sitting down and standing up. If you're in the hospital, sometimes they do it laying down and sitting and then standing. But really, we talk about brain fog. We talk about fatigue, anxiety, exercise intolerance. And many times these patients are coming in to see you as therapists. You may be experiencing it after an infection. And then it's triggered by an immune activation, usually a viral injury. And sometimes we'll actually see it involve small nerve fibers. This is an example of what a postural or orthostatic tachycardia exam looks like. This is the orthostatics, we call them, where we have people sitting and standing. And then we see, and sometimes they'll say, ooh, I'm dizzy, I see stars. Or they'll say, ooh, I feel a little faint. Please make sure that there's a chair behind them, obviously, when you're doing these. But you can do an easy one, like just have them stand up. And if they feel a little dizzy, you know you may need to take their blood pressure and heart rate.
So I want to talk a little bit about what some of the symptoms of POTS look like versus anxiety, because you all treat patients with anxiety. So how do you know what are the flags to look for to say, hey, maybe this is not just typical anxiety, but there's actually POTS. And if you look at these two lists, the list on the left is the symptoms of POTS. And the list on the right is the symptoms of anxiety. So POTS is characterized by dizziness or lightheadedness, shaking and sweating, weakness and fatigue, shortness of breath, chest pain, fainting, heart palpitation, headaches, and poor sleeps. If there's anybody here that has never seen a patient with this list of symptoms, I'm going to need to find out what happened. Like, that is not possible. We've all seen this exact list of symptoms, right? So this is a huge overlap with anxiety. So you can imagine these patients maybe are feeling this way. Someone who has this list of symptoms, where are they going to go? A therapist because I have anxiety, the ER because I have a panic attack, and they're told your heart is fine. It's a panic attack. They come to a psychiatrist. And so I've had multiple patients who come to me as a psychiatrist looking to treat their anxiety, and it's actually POTS. Now, they're not mutually exclusive. There's no rule that says just because you have POTS, you can't have regular anxiety on top of that. In fact, I have a patient with POTS who has very straightforward, clearly diagnosed by cardiology POTS, but she also meets criteria for severe OCD and depression. And, so there's both going on. So as you see, we are very familiar with the symptoms of anxiety, and that the panic attack symptoms very much overlap with the POTS symptoms. There's a few distinctions. One, excessive worrying is not a symptom of POTS, and the cognitive distortions of the all or nothing and the black and white, the negative bias, those sorts of things are not. So the negative thinking is unique to anxiety, the worrying, those are kind of differentiating features. But the biggest differentiating feature is that it is positional. That's in the definition of POTS, it's positional. And so anxiety can get triggered in lots of situations. You're worried about things, you're thinking about your work stress, you have to go somewhere, or something, situationally, emotionally triggers the anxiety, whereas POTS is triggered by a physical position. So I give an example when it comes
Don't
to
have to be
like,
3 months.
oh, sorry, got distracted by somebody's mic not being off. So I had a patient come into me for depression, and she goes, I'm just so depressed. I'm so anxious. I can't do anything. I'm not functioning. I haven't showered in 2 weeks because I just don't have the strength to wash my hair. I can't keep my arms over my head. Excuse me, arms over your head is not a symptom of anxiety. That is exercise intolerant, and it's triggered by the shower, right? So you're in the heat of the shower and you have to lift your arms and wash your hair. And she's got long hair. She actually got a haircut to make this easier, but she has really severe POTS, as it turns out, but she didn't know. And she came to me for psychiatry. And I said, look, sure, you do have depression. Your husband is dying of ALS, so you should have a reason to be, but that does not mean you can't wash your hair in the
You do
shower.
not.
That's something else going on. You need to go see a cardiologist. So things like that just don't sound quite right, that sends off, you're like, hey, that's not typical. That probably means it's not typical, because you know what you're good at and you've seen a lot of it. So it stands out when it's different. Other examples that kind of stand out position wise is if they wear those, any kind of wearable, or a ring, Fitbit, all the different ones they have now. And as they're doing yoga, and they bend over and then stand up, and then they had to leave the yoga class because they got a panic attack because the anxiety happened, right? So when it's triggered by movements, they get up from the couch and they feel really faint and lightheaded and things. So looking for those kind of red flags of it being there, especially if you ask about their panic attacks and that they all happened when they changed position, either bending over, standing up, those kind of things would be what to look for in telling your patient that we need to look more closely at this.
Absolutely. And I know I have teenagers. I see a lot of teen young women who all of a sudden they were fantastic athletes, and then all of a sudden they can't play their sport because every time they have heat intolerance, they have different types of positional, like Dr. Licardi was saying, they have different types of symptoms related to the activity that they're doing that it actually changes their behavior and they become not athletic anymore. They start missing out on behaviors. And then so I often say, what started it? What started? Was it the POTS? Was it the anxiety? What happened first? It doesn't matter. We just have to get to the bottom of it and get our patients feeling better.
Had a tennis player today who she couldn't she was not feeling right in tennis. I go, yeah, you're bending down to pick up the ball and standing back up, and that's making you feel lightheaded and woozy. And so your blood pressure is dropping.
Yeah.
And I was like, let somebody else pick up the ball. Keep playing. Don't bend down.
You're funny.
We don't need you to faint on the tennis court.
Have you ever done that with your tennis ball? Like pick it up with your foot? I can't do that.
I'm not good enough to
I'm
do
not
that.
good.
She is. She could do it. She's very good.
Oh, well, she could do
Maybe
that.
she could do that.
Yeah. You're funny. Okay.
Can
So
you see this?
mechanisms of dysautonomia. Yeah, I can totally see it.
Okay.
So mechanisms of dysautonomia. There's actually 4 types of dysautonomia. So if you are not familiar,
Sorry.
I do not diagnose dysautonomia. I always do refer to cardiology, either pediatric or adult, for a formal diagnosis. And we're going to talk about that in just a little bit. But there are different things that we look at. We look at autoantibodies. We look at adrenergic and muscarinic receptors. We look at inflammatory cytokines. So like that cytokine storm. A lot of people may remember that term from when COVID first happened, or maybe from school if you talked about it. That's when those symptoms first present and they are very, very ill. It starts with this chronic inflammation and cytokine storming. Mitochondrial stress, anything with energy depletion, you'll find them where they actually get short of breath, doing minimal activities if they stop, if it progresses enough. And then we also see vagal nerve dysfunction and small fiber neuropathy. Symptoms, fatigue, malaise, fever, right? Again, because there is an immune modulation that is happening. And we do see oftentimes and this is actually really interesting too, because I bet you it's a lot of pain too with Dr. Amen's new book, when I was just thinking about the small fiber neuropathy, but like the symptomatic changes that happen, the plasticity that happens over time, those can all be impacted by immune system and the autonomic nervous system. So the immune dysfunction, I love the immune system. I think it is so fascinating, but we're looking at what happens with a persistent immune activation after that infection, right? So we look at the cytokine storm. These may be familiar to you, they may not be. These are things that we can test here at Amen Clinic, IL-6, TNF alpha. We can look at the interferons. We can look at different types of viral infections. And then we actually look to see how these things are progressing in the patient. We look at autoantibodies. Microglial activation is huge. Microglial cells, if you don't know, they are the part of the immune system in the brain, right? They are actually that macrophage of the brain. And
Cleanup cells.
The cleanup cells, the little Pac-Mans, I call them, right? They're going around eating all the bad stuff that you want them to do. But what happens is that cytokine storm creates a mismatch, this chronic inflammatory response in the body where the innate immune system and the adaptive immune system start not to communicate as well as they used to. It becomes overactive. And all of a sudden, we start to see this T lymphocyte activation, which again is part of the immune system. And then that is what ultimately leads to the neurologic dysregulation that happens, creating this inflammatory response that we call postural orthostatic tachycardia. This is my favorite conversation, right? So this is one of my favorite topics to talk about is endothelial dysfunction, because ultimately, when we talk about the brain, and actually the entire body, when we talk about chronic inflammation, starts and ends with endothelial dysfunction. It has to do with the blood vessels. And again, we're made head to toe with the blood vessels. And we know that SARS-CoV targets the ACE2 receptors, come on in the endothelial cells. Right? And it leads to this inflammatory response where blood vessels get a little bit irritated. You may see an increased CRP, C-reactive protein, but ultimately you're going to see poor vasodilation because of the limit in nitric oxide production that happens over time. And the interesting part is it actually is a microinflammation
It's
that
just, it's three
reduces
steps
the
forward,
oxygen
100 steps back.
delivery
It's
to the
been
body.
like this for
So
decades.
people actually will
Today,
say,
with
my
Health
hands
Back for
and
the
feet are
first
cold.
time in more
And
than
I
50
often say,
days,
when your hands
Democratic
and feet are
Congress.
cold and it's not cold out, like it shouldn't be, your hands and feet should not be cold. That is actually your nervous system. It's not necessarily just your circulatory system, because the nervous system vasoconstricts those blood vessels. So the blood can't get to where it needs to go. If it's not getting to your fingers and toes, there's a good possibility that's not perfusing the brain the way it should be. And then we start increasing mitochondrial dysfunction anywhere in the body. There's mitochondria in every cell of the body, to include the muscles and the heart and the brain. And it increases something called reactive oxygen species. When we start talking about energy production, we actually see limited energy in these patients. They get tired doing simple activities. So endothelial dysfunction and nitric oxide production is ultimately the core of many chronic illnesses, to include POTS, dysautonomia, and many brain diseases. Yay. So hold extremities. I just mentioned about your fingers and toes, right? That is oftentimes a cortisol issue, which is the adrenal glands and the brain. You'll see exercise intolerance. And I often use the example of someone who's walking up a flight of stairs who has to stop at the top and catch their breath. It's like a little mini stress test. They can't go on. They have to stop and catch their breath. We'll oftentimes see chest pain and palpitations, which do make us nervous, right? We don't want people having chest pain or palpitations in our office. But then also the brain fog and the impaired cerebral perfusion, which we're going to go over because we can see it in the SPECT scan, which is really not fantastic in a good way, but we want to be able to see it. And then the headache and the dizziness. And it all, again, has to do with something called reactive oxygen species, which happens in the mitochondria and the electron transport chain, where we see a decrease in nitric oxide and we see an increase in this inflammatory response and a decrease in endothelial repair. And then that creates oxidative stress. Oxidative stress has to do with chronic inflammation, simply put, oftentimes leading to that mitochondrial damage. Ultimately, it's a reduced ATP, which is that energy production in the cell, which causes fatigue and autonomic instability. That's the nervous system, right? So you can see here, we have mitochondrial dysfunction. We'll start to see telomere shortening. We can actually test your telomeres. I don't recommend doing it all the time. You can do it once in a while because it doesn't really change very fast, but we can do that here at Amen Clinic. And we start to see neuroendocrine abnormalities. Diarrhea is a perfect example of neuroendocrine abnormalities. People who eat and then have immediate diarrhea. It could be lots of things, but one of the things it could be is also related to the nervous system and a mismatch in that system. And that oxidative stress impairs neurologic function and ultimately recovery.
So anxiety and neuropsychiatry. So we got into this a little bit on the other set of slides, but as you said, the autonomic nervous system imbalance. The parasympathetic is your rest and digest. Your sympathetic is your active state, your fight or flight mode. And so having this high sympathetic tone, we're in this high tension, high anxiety state because we have the sympathetic nervous system overactivated. We find hypo, meaning low perfusion, especially in the prefrontal cortex. We have overactivity in your limbic system, and then this cytokine-induced neuroinflammation shows up on our SPECT scans as overactivity on our in just kind of widespread over busy brains, that your nervous system is just revved up too much. But then all of these things, they have a medical base for having POTS, right? This is a physical illness that triggers a physical reaction, but it has so much psychiatric impact, right? They then also often develop depression, anxiety out of the trauma of this experience, right? You're now having panic attacks. You're having a lot of fallout from the physical illness, then gives you secondary, you develop anxiety on top of it.
Yeah, especially in our menopausal women, right? Perimenopausal women who are told you're fine. Why are you here, right? Everything, all your tests are normal. Maybe they didn't do orthostatics. They just did a blood pressure, right? And a heart rate. But again, like it's taking that next step. And that's why it's so important for therapists, because people come to you and they just let it out, right? They just let you know how they're feeling. It's being able to kind of take that next step and say, okay, what's the best thing for this patient right now?
And I have a great example of a patient who was actually sent by one of our wonderful therapist in the area, and sent the patient because she had I lost track of how many people she had lost. The amount of grief and suffering that she went through. It was like multiple deaths within like a 2-year period. Her mother, her brother, her husband got a brain tumor. Like it was like anything that you can imagine. And so it was just really so much grief. And so she had lost her job and all these things. And so understandably, she has a lot going on situationally. And they're like, okay, she needs some medication. This is just too much. Been in therapy for months. And then even in the first 3 appointments that I saw her, more people kept dying. I'm like, you can't, we got to stop. Like, this is just so much grief, right? So recognizing you can have anxiety, depression, grief. But on top of it, she's describing these things to me and she's having panic attacks. But again, it was like, this isn't right. Like, this doesn't make sense. And so I was like, well, propranolol treats anxiety. So I'm going to give you that for your panic attacks, but don't take it as needed. Take it every day and see what happens with these POTS symptoms that you're describing to me. I'm like, see if this sounds right to you, if that's familiar. And that was it. I mean, I don't diagnose and treat POTS. I treat anxiety, but propranolol happens to be a medication that does help with POTS because it sets a limit to your heart rate. It's a blood pressure medicine that controls your heart rate. And so it really makes a big difference to alleviate those POTS symptoms. And she goes, I can't believe what a night and day difference the propranolol. Now, if it's plain anxiety, it's helpful. It's a good medicine. But her profound benefit was because the propranolol was treating her POTS as well as her anxiety.
Interesting. Yeah. So chronic fatigue, brain fog, and sleep. I don't know who hasn't heard some of these symptoms from our patients, but we can see from that cranial nerve number 10, the wandering nerve, the vagus nerve, we'll see a vagal dysfunction that disrupts the sleep-wake cycle, specifically because it interacts with the adrenal glands. You've got two, one on top of each kidney. They wake you up, they put you to sleep, and they help you run away from a bear or a longhorn in Texas.
I'm going to take Jackie to go see cows on
So excited.
We're going to go do the cattle running forward.
I'm so excited. And that disturbed sleep. That's going to be so much fun. But that disturbed sleep ultimately impacts deep sleep. So there's deep, there's light, and there's REM sleep. Deep is always in the beginning of the evening. So if you're not able to go to sleep, if you're laying in bed wide awake, you certainly need to talk to your therapist, your doctor, your nurse practitioner, your somebody. You need to talk to them because you have limited glymphatic clearage. So glymphatic clearage is what happens during deep sleep. And it's kind of like when the janitor comes out to clean up the mess, right? So if you're not sleeping, your brain's not properly able to detoxify. And we talk about detox, right? Whether it be from medications, whether it be from substances, we talk about phones, right? We got to detox from lots of different things, sugar. But we also have to detox our brains. It's so important. And then poor perfusion ultimately equals low oxygen to the brain. And that is something that we don't want. Anything that increases perfusion in a healthy way to the brain is what we want to do. And when there is that decrease blood oxygen to the brain, we'll often see that brain fog because of mitochondrial depletion. These are other things that you'll see. Weight gain will increase because cortisol is being activated, increased body mass, other obstructive sleep apnea, triglycerides, again, because of the sugar and the cortisol, but also the total cholesterol and LDL will change because, again, when your hormones change, the cholesterol also changes. What comes first? I'm not sure, the cholesterol or the hormones, but they both work together. You'll see them go up. So if you have a patient who comes in and they're like, my cholesterol shot up, my triglycerides, I have sleep apnea now, start to think about what's going on from a dysautonomic standpoint. And then testing. So like I said, CRP is something you'll see. It's an inflammatory marker of the blood vessels. We're made head to toe of blood vessels and all the organs in between. IL-6 is a little bit more tricky to order, but we do order it here at Amen Clinic. Ferritin we do on every patient. The autoantibodies are so important, as are, you can test L-arginine and also nitric oxide in a blood panel. What the cardiologist will often do is a tilt table test. And that's something that's specific, that's done either in an inpatient, not inpatient, but in an office, a cardiology office or hospital office. And then, of course, we do SPECT scans, and we can do those here.
And a tilt table is exactly what it sounds like. It is a table that you lay on and they tilt it.
That is Remember the tilt-a-whirl?
Oh, yeah. So they lay you flat. They actually lift your feet up a little bit. You start a little bit down and they go. really quick. And so it just changes your body position very fast to really trigger that reaction. So that if any positioning change, because sometimes people auto correct, like you don't want to faint, so you go a little more gently, and that does so this forces a very quick change in position that will set it off if it's present. So looking at brain SPECT scans. So first we're going to look at a healthy scan and what a brain SPECT is, and then how we can see these kind of findings on people who have experienced this stuff. So a brain SPECT scan is measuring your brain activity by looking at blood flow. If you've been to these things before, you've probably heard some of this stuff, but I always just start from scratch and explain it all from the very beginning. So what we're looking at in your brain on a brain SPECT scan is what is the brain's blood flow? Does it have good, even blood flow? Are there areas of overactivity and too much blood flow? Are there areas of underactivity and too little blood flow? So when you come in, you get an injection. It's a radioisotope that sends off a bright signal and it's read by the camera. Then the computer takes all of those pictures and makes a 3D composite to let us look at the outside surface of the brain, which are the rainbow color scans here on the left, and the inside emotional centers, which are the red, white, and blue scans on the right. When we look at the surface scan, the rainbow colors don't matter. They mean absolutely nothing. It is just the shape. Everywhere you have good blood flow, it sends off a bright signal and fills in evenly. If there's an area of low blood flow, it sends less signal and will make a dent on the SPECT scan. If you have a 45% drop in blood flow, that looks like a hole on the SPECT scan. That is not a physical hole in the brain. It is an area of low blood flow. That is a reversible finding. We can restore blood flow and make it better. And if you did a CAT scan or MRI, we expect those are typically normal, that the structure and the anatomy are still intact, but the blood flow is low. A CAT scan and MRI are structural scans. They look at the physical anatomy and the brain tissue, which are really important tools to know if you're in an accident. Did you have a skull fracture, a brain bleed? The ER is going to do a CAT scan to find out what's happening with the anatomy. If they think you have a brain tumor or something else, they're going to get an MRI to get a really clear picture of the anatomy. So those are great and we need them, but they don't tell you anything about what the brain function or the brain activity is doing, which is what we're able to look at on the SPECT scan. So rainbow colors don't matter. Denser holes are areas of low blood flow. Then we look at each part of the brain and say, what is that part of the brain responsible for? So what kind of symptoms can relate to that activity? Then we look at the inside. Here, that's the red, white, and blue, and the colors do matter. So blue is your background. That's your baseline or resting level of activity. Red is more blood flow, higher activity, and white is the most blood flow, the highest activity. In a healthy scan, what we expect to see is mostly blue, a bit of scattered red in those emotional centers. We should have some emotional center activity, not zero emotions. That doesn't feel good either. And then we want white in the cerebellum. That's the highest level of blood flow. You have about half your brain's neurons jam-packed into the cerebellum. It's very dense, so it should be getting more blood flow and show up as white on the scans. So that's a healthy scan and what we expect to see in an average brain activity. So we kind of explained this a little bit. So what are some of the findings that we see in post-COVID and these inflammatory conditions is that when we look at the SPECT, we can tell what is the brain health doing based on what is the overall blood flow pattern. So we see low blood flow in the frontal lobes. The job of your frontal lobe is your focus, attention, concentration, decision-making, planning, and impulse control. So when we see low activity in the prefrontal cortex, that looks like getting easily distracted, difficulty completing tasks, struggling with time management, organization, poor concentration, and impulsivity. We see trouble with executive functioning, trouble with complex decision-making and planning, which is especially the job of the prefrontal cortex and the cerebellum crosstalk. So the right tells the left and the left tells the right. They have these cross signals between the frontal lobe and the cerebellum. That's really the executive functioning when they work together in that. So as they decrease, then we have trouble with that complex decision-making, planning, problem solving. The job of the cerebellum, which is also decreased in the scans, realize we have global findings. So if you're affecting the whole health of the brain, the cerebellum is the densest part. So it's going to drop out and really be affected by that. And so we see trouble with balance and coordination. I think of a field sobriety test as the way to remember what the job of the cerebellum is. That's exactly what they're testing. So walking heel toe in a straight line, touching your finger to your nose, that's the job of the cerebellum. And then we see high activity in your limbic system. So we're supposed to see a little bit of scattered red. We talked about that. Emotional centers, we see high activity overactive in those areas. So typical SPECT findings in a post-COVID, we see the low global hypoperfusion, decreased activity in the temporal and frontal lobes. The temporal lobes, think of your temples, so they're right here, and their job is your mood regulator. They're in charge of keeping your mood steady or even keeled. So we see moodiness, waves of emotion, flashes of anger, irritability with low temporal lobes. Big job of the temporal lobes is your hippocampus are in here, which is your new learning. So to learn new information, that's right in that temporal lobe. So new learning, naming, word finding. So this is forgetting the word in the middle of a sentence, having a hard time remembering people's names, problems with your short-term memory, and new learning. And then we see high activation in your limbic system. This goes along with this regulating your sleep. So the sleep disruption, anxiety, mood changes, and then the cerebellum. So this is a scan. I love this story. This is one of our favorite patients that we share because he's doing amazing.
Amazing.
Amazing. So this is a patient who his background is he came to me and we were his Hail Mary. He has given up and he's told me he will not live like this and he will kill himself if this does not get better. And he was like, yeah, good luck. He had already been to Cleveland Clinic and Mayo Clinic for post-COVID, told that he has long COVID, and then good luck. And they really didn't do much to help him. He went to a local integrative doctor who's like, oh, yeah, and you've got mold toxicity. But then as he came to me, I'm like, well, what happened with that mold toxicity and your post-COVID? Where do we stand with all that? He had made progress. The doctors he'd seen had really tried and had given treatments, and he had made improvements. So he had gotten better than where he was, but he was very high functioning, high profile before this. And he's like, I can't do the most basic things. And he was performing at a very high executive level before all this happened. It was forced into early retirement because of his post-COVID syndrome. And he's like, I will not live the rest of my life like this. And so as you can see, his scan looks terrible. And I'm like, yeah, of course you feel awful. You're used to being at well above, I mean, he well above average kind of lifestyle, achievement level. And now you've got severe decreases in your prefrontal cortex, these large holes, that's very low activity. And his whole left temporal lobe is like hardly anything. You just see it's like this little thing sticking out, right? It's not filling in. So all these holes, those are the areas of low blood flow. And so he came in, depressed, suicidal, highly anxious, lots of cognitive distortions, just saw no hope that nothing is ever going to get better. And you see that all this low activity, these global decreases on the rainbow scans, the surface scans being low, and then that matches here on the internal activity. We see that lack of white in the cerebellum. The cerebellum is really low. We should be seeing white and red, and there's hardly anything in there. It's super low. And then all of it is here in the thalamus, which is a relay center. That's this big white spot in the middle that you're seeing. We have the mouse actually working. So this is the thalamus here. And this is the cerebellum being low. So the thalamus is a relay center. It sends a lot of messages and it's involved in regulating your sleep, your appetite, and your libido. So when we see this high activity in the thalamus, we see dysregulation. It can go up or down. So you can get hypersomnia or insomnia. You can get increased appetite or loss of appetite. And we see the libido dysregulation, temperature dysregulation, all of these things. So his scans are like the classic finding of, okay, you've got post-COVID and you have exactly what we expect to see. He'd been to so many doctors that it was a mystery. Nobody knew what to do, what to tell him. And even I saw him last week and he told me he's doing 80% better. And he goes, but you've seen this before, right? Like you can help me with this. Like he's been so at a loss for anybody to understand or have any idea how to help him, even when he's 80% better, because his cognitive distortions are still very skewed. We're still working on that. And I'm like, you're doing so much better. Remember how it was.
Yeah.
And
that's important too, right? Is having patients remember those symptom scores are so nice to have people do. So you can like show them because progress sometimes is very slow, right? It can be very slow. It's not happening overnight. And so showing them kind of like, where have you been?
Yeah.
Right. And they're like, oh my God.
Yeah. So we've gotten past the suicidality, like this, but he's still, when am I going to be 100%? Well, your mold score still came back high. You got new carpets, but we're not done yet. Where's the rest of the mold in your house? So we do have to fix that. So he's still getting exposed. But in his situation, he had post-COVID, long COVID, and on top of that, living in a moldy house. He had mold. They had flooding in the basement. They had a bathroom leak. Like it was like 10 different problems in the house that was giving them mold. And they needed to like get it all removed and cleaned out. Yeah.
Big deal.
It was a lot.
Yeah.
One of the things I love about scans every day when I sit down with patients is the sense of validation that they feel that this is not just me, this is my brain. And I had a patient who was really impacted by this is not laziness, this is not a character flaw. One of the women we both saw today, right? She's everything wrong you could imagine. She came in, she's like, I'm just staying at home. I'm not doing anything. I drop the kids off at school and I go in bed all day and I don't have any motivation. And then I pick them up from school and I've gotten nothing done and my house is disgusting and I'm embarrassed and I'm just so lazy. She's not lazy, she's sick and her brain looks terrible. And we did her blood work and she's got
Blood work's pretty bad.
blood work is horrible. So she had undiagnosed diabetes, hemoglobin A1C over 7. So not pre-diabetic, actually diabetic, and untreated, uncontrolled blood sugar will give anybody terrible energy.
That
right?
causes endothelial dysfunction all by itself. And then uncontrolled triglycerides.
Yes. Undiagnosed sleep apnea.
Oh, yep. I forgot about that one, but yeah.
That one, yep. She had like a B12 of like nothing.
52.
Lowest one I think I've ever
52,
seen.
yeah.
52. Normal is 500.
And her folate was 3.
Yeah. Normal is 50.
Yep. She did have a COMT mutation. We did look at her genetics.
Yeah.
So
So she has like 10 underlying medical problems that give you fatigue. I'm like, you're not lazy, you're exhausted. Like you have no energy stores to be able to function and do these things because you have no blood sugar regulation, you have no vitamins, you have your blood cells don't have what they need. So you've got anemia and it was just so validating for her to see, okay, your scans look bad, so let's get some blood work. Okay, your blood work looks terrible, so that explains everything. And being able to realize this is not a character flaw and this is treatable. Now, it's a lot of work.
It is a lot of work. CRP was 30. The highest CRP I've ever seen is a 99 in outpatient setting.
Normal is 3 to 4.
Normal is 3. So she was, and so we were moving pretty quickly with getting her on the appropriate medication and drugs and teaching her how to do it because it's a lot, right? This is what we ask patients to do is not easy. And I think what we excel at is really breaking it down and explaining it and giving people a process. Like, how do you process this information? Because don't forget, their brain's affected, right? So it's like an injury. It is an acquired brain injury, if you think of it that way. So helping patients, giving them hope. Like she had no vitality. I mean, no wonder. I mean, her P12 was 52. Like she had no vitality. She had no energy. And like, you could just see like, she was kind of like, oh, like it's not me.
Yeah. And she came in today and she goes, I have a living room floor.
Yeah. Yeah. I can see it.
I can see my living because it was just piles and boxes and stuff and clutters. And, she felt very alone in this. Her teenagers were not cleaning up the mess and it was all on her. Her husband's at work and, hey, you stay at home. Why aren't you cleaning this? Right. There's a lot of shame going on.
And she's perimenopausal. That's another. We're doing that next.
That's going to be next time. We're going to wait.
Yeah, we got to get the cardiac stuff figured out. But so like this is a work in progress. Nothing happens overnight, of course, but it's really about partnering with the providers, but also partnering with the patient, right? How do we get the patient, number one, on board to guide individualized treatment? The SPECT scan is an individualized diagnostic exam that helps drive treatment. And really, what I say to patients is we don't guess. I'm not guessing on any of these things. What I'm doing is we test, we treat, we retest. We're going to be retesting her sooner than later because the numbers were pretty bad. So we have to make sure that she's metabolizing the medication, that she's absorbing the B12. Like, so she has a COMT mutation. So her traditional doctor gave her cobalamin. She can't have cobalamin. She has got catecholamine methyltransferase issues. She needs methylated B12. Her MTHFR was normal, but she still couldn't do it. And she's like, I don't drink coffee. And I'm like, yeah, because you're kind of like this, right? Like, like I realize that, right? So like she left here, I think, with a smile.
Yeah. And hope. And so I always want patients to walk out with hope that, look, this is not all in your head. This is in your brain. This is really happening. Look what's happening. And so the SPECT scans are a great tool to help family also understand what's going on. And so I can't tell you how many appointments I have where I'm explaining something and the wife is going, uh-huh. And they're like, yes, yes. And the guy's kind of, and she's like, yes, yes, right. So that's able to make sense of it, that they say, well, it's stuff that they haven't even reported or isn't in their history. And I'm like, well, this part of the brain usually shows up with this kind of symptom. And they're like, that makes so much sense. And so being able to then say, okay, what do we do about it? How do we optimize it? And it's so destigmatizing because we're talking about, look at your scans. This is your brain. How do we get you the healthiest brain possible? It's non-judgmental. It's not stigmatizing. And it gets people on board, because the idea around nobody wants to have a mental illness, but we want healthy brains. We want to make these positive changes. And my appointment, literally right before this, that I haven't written my note yet for, he's known he has an undiagnosed, he goes, I don't know, like moderate sleep apnea, wasn't sure. And I said, well, tell me about your sleep apnea and your CPAP. What's going on with that? He goes, it's brand new in the box and it's like 3 years old. And I said, well, can we go find it and see if it's got all the parts and like try, like he has not done a thing to treat his sleep apnea, but it's showing up on his scans. And
sleep apnea is a big deal.
It's a huge deal.
Yeah.
And so his scans looked terrible. He's a young guy and he's got this really low parietal lobe. And I'm like, this is classic what we see in sleep apnea, and this sets you up for Alzheimer's. And we really don't want to go down that path. And so when he came in, he was not motivated at all to do anything for his sleep apnea, because he had not done anything in the past 8 years that he's known that he had it. And he even got like he's gotten an update sleep study, went to the doctor, but then never followed through on any of it. And so we walked out of here and he's going to go find his CPAP and at least give it a try. So then if you're not going to use it, you have a documented failed trial and we can go on to other options and try something else. But at least let's start doing something with that.
And again, if you're not sleeping, that lymphatic drainage, that lymphatic detoxification isn't happening, right? That way the brain detoxifies. So he's not getting into good deep sleep.
Mm-hmm.
We should do a conference on that, deep sleep.
Yes.
Next one,
Lisa Marie.
Next one. So management strategies. So when we start talking about postural orthostatic tachycardia and dysautonomia, how do we retrain the brain, right? So everything that I do for my elite athletes, I actually do for my POTS patients, but we do it much slower and in smaller portions. We want to grade the exercise. So start with walking. I say, just get your sneakers on, find your sneakers, get them out of the closet, put them on, make a habit of actually doing something, right? And it takes 3 weeks to build a habit. But again, this is a lifestyle. It is not a one-time thing. This is a lifestyle we're trying to create.
I had that conversation with a patient last week. He had moved. He didn't even know where his sneakers were. I said, okay, you're overwhelmed, because he does great when he walks. He loves walking. It's really good, but he hasn't walked in a month. And I'm like, well, where are your sneakers? I don't know. They're in a box I just moved. I was like, so today, go find the sneakers. That's it. Find them by next week. That's your goal.
Yeah.
Like, we aren't even he used to walk 3 to 4 miles a day, and he hasn't walked at all in like 2 months because he doesn't know where his sneakers are.
Yep. And Dr. Amen just did a TikTok or whatever, an Instagram, one of those things on this. And there was a research study that came out that showed that got graded walking. So when you walk from an Asian study that came out that looked at where you walk for 4 minutes at a casual pace, and then you pick up the pace. I usually say like you're walking late for a meeting, but someone with POTS can't do that. So they just increase it just a little bit, not like you're late for a meeting, but just walk fast and slow, a little bit faster, a little bit slower. I mean, we don't start there, but that's what we're working towards. We're looking for hydration. A lot of people say, I just forget to drink water. And I'm like, okay, well, we need to figure out a way to fix that. And then salt. So when I work with, I share a lot of patients with the Johns Hopkins Postural Orthostatic Tachycardia Clinic, and we're going anywhere from 1 to 10 grams of salt a day, right? So 3 1,000 milligram salt tablets with breakfast, lunch, and dinner sometimes, depending on the patient. Don't start there. Please communicate with your providers before you do that. CoQ10 NAD available oral as a injectable into the arm or as an IV. You can get NAD, magnesium, antioxidants. I love our vegan fish oil has SPM and fish oil in it, which is fantastic. It's 2 for 1. That's what I like to call it. But SPM activates the microglial cells of the brain. So that immune system of the brain gets activated with the specialized pro-mediating resolvins. I think they are probably the biggest breakthrough in fish oil medicine, if you look at fish oil, and mitochondrial medicine in the last 10 years. I think it's really fantastic. Curcumin and then the low inflammatory diets. The curcumin is going to be typically 500 milligrams twice a day. Again, anti-inflammatory doses. And then the restorative sleep, CPAP. figuring out sleep. I always say, is it your husband, your wife, a cat, a dog, a child? Like, who's in your bed preventing you from sleeping, right? Like, is that an issue? Do we need to figure that one out first, right? And then how do you regulate your sleep? Again, if you can't fall asleep and stay asleep, there's other issues that we need to work on while we're doing all this work with your blood pressure and your heart rate. And then therapeutic pacing. Again, everyone's not going to move at the same pace, and I don't expect everyone to do that, right? Everyone is an individual, and we have to meet the patient where they are because many of them are going to have that post-exertional fatigue, which is where, Jackie, went ahead and I did this, and I was out for the next 24, 48 hours. I just couldn't move. Well, you did too much, right? We got to take it back a little bit.
And this is a key feature that as a therapist, you're like, all right, let's get going. Let's exercise for 30 minutes a day. And they come back to you and they don't tolerate it. That's not normal.
Yeah.
Anyone should be able to do some exercise and not feel like they need 2 days to recover from it, or they are just wiped the rest of the day. Exercise should be invigorating. Yeah, you may feel a little worn out, but you feel better. If you feel worse when you exercise, that means there's something medical wrong with you that you need to get that looked at.
Another one too is besides the post-exertional fatigue, it's also the pain. So if you and I were to do squats, it is normal for our legs and our tushy to hurt a little bit. That's totally normal. It is not normal for them to hurt 48 hours later. That is, again, a sign of hypoperfusion in different parts of the body. Again, a little bit of pain is normal. A lot for a long period of time is not. And again, that post-exertional decrease in mitochondrial response.
So brain health integration, normalizing anxiety and fatigue as a physiological response. We use cognitive behavioral therapy, targeting the distortions, the negative thoughts, the negative self-talk, mindfulness, grounding exercises, really recognizing the social isolation and the fear of relapse. So being purposeful about connecting with others, about staying involved, and not drawing into that hole of shame.
With high schoolers.
Yeah.
The young kids. Oh gosh, it can be life-changing. It can really just set off the trajectory in a different way. Yeah, and then collaborative care.
That's all we do. I can't tell you how many times I'm like, okay, so I can help you, but you need Jackie. Like, she's going to really help you.
Let's get to work.
So key takeaways, post-COVID illness is your whole body system. It's your immune system, your vascular, your neurological symptoms. You experience dysautonomia and endothelial dysfunction. Quick, making sure everybody's on the same page. Jackie, what does endothelial mean? What are those?
So the endothelium is the lining of the blood vessel. Again, we're made of blood vessels from head to toe and the organs in between. So it's actually, if you consider it a smooth structure that lines the interior of the blood vessel, it is what actually helps constrict and dilate that blood vessel. If you can't constrict and dilate because of high blood sugar, hypertension, arterial sclerosis, which again, all lead to or result in endothelial dysfunction. Every chronic illness has a issue with endothelial.
So if you imagine your blood vessel, you take a cross section and then you have the cells, the different layers of that blood vessel. The innermost layer of the inside of the tunnel, that's your endothelial cells. And that's what's in charge of all of these things. And then they get weak and they get leaky and they aren't strong and they're not doing what they're supposed to do.
Yep.
And then
leaky brain, leaky vessel. So
leaky gut.
Leaky gut.
So
leaky
this is
brain,
what
leaky
leaky gut
vessel.
is. It's the endothelial of the gut. That is what people call when you say leaky gut.
So I always say, this is what your gut wants to look like. This is what your blood-brain barrier should look like. And then when it becomes leaky, we start to see that perfusion, where stuff can get in between. There's not a carrot floating around, right? But like if you eat a carrot, it's not like that. But it's that cytokine, right? That immune response that creates it.
And this is on a cellular level. You're not seeing this, but if you microscope it, then you see it.
Blood work.
And then the blood work see. Yeah.
And that's it.
So we did.
Oh, well. Healing the brain takes time, but you got to heal again, it's not just mental health. I don't like that word, mental health. It's really brain health, right? And brain health starts with the endothelium and it continues with, so diabetics, hypertensive, young, old. I saw a 15-year-old who was almost diabetic, right? And it was all lifestyle. So it's starting younger and younger than what we're used to seeing, right? When we were first starting out. So this affects everybody. And we're so delighted to be able to talk about
And
it.
I tell people all the time, your brain is an organ in your body.
Yeah.
So if something is happening in your overall body, it's happening in your brain. Your brain is affected by everything else that is going on. So if something is happening, it's happening everywhere, including your brain.
Absolutely.
Yep. Awesome, guys. Thank you so much.
Thank you so much, Dr. Liccardi, Jackie Meinhardt. So nice to meet everybody. Thank you so much
Thank
for
you for
coming.
those of you who came in person. I love having in people in
Yes.
person.
Does anyone have any questions? We're happy to answer any questions.
Yeah, for those of you that are on Zoom, please feel free to ask your questions.
You're muted.
Is it picking up over here? I don't know.
Okay, for those of you guys on the Zoom, please feel free to ask your questions live, or you can put them in the chat.
I'm going to turn off the screen share, right?
Yeah, go ahead.
And then
Do you want to go to chat?
yeah, I'm going to find it. There we go.
Can everybody hear? Yep.
No. Anyone in here have any questions?
We'd love to answer them. Has anyone ever seen postural orthostatic tachycardia? You have? You've seen it?
I have a 17-year-old client with it.
Got it. Yeah.
And I wonder, so my question actually is, there's no history of long COVID or anything like that, but there is a significant trauma history with a lot of physical abuse in it. Is that something that can bring on POTS and also just all of the things that go with POTS?
Yeah. So we talked today about post-viral illnesses, right? Specifically COVID, but I honestly believe, and this is documented in the literature, the medical literature on PubMed, I'm happy to show you. We know that whether it be viral, bacterial, parasitic, physical, emotional, real, or perceived, you can have an immune system response. And people will say to me oftentimes, and this is where I say like that chronic inflammatory response happens, because they'll say this happened and I've never been the same. I believe you. And I think that's one of the most important things I tell patients. I believe you.
Because nobody has believed them.
Because no one's believed them. It's almost like this, what is it, PTSD, this medical PTSD that happens where patients they're afraid to tell you what's going on because they're afraid you're going to be like, oh, you're fine. You're not
Well,
close.
being told you're
All the time.
you're anxious. That's everybody's problem here.
Yeah. But you'll see actually there's a really interesting, when you look at cardiology, there's a really fascinating new research going on with women and hormones. So we know that estrogen modulates cardiovascular and blood vessel response. Hence the reason why as women go through menopause, we'll see more and more of them with hypertension, dyslipidemia, right, who haven't been on estrogen or hormone replacement therapy. So there's this research agenda that's happening, which I am all for, right? Celebrate the woman, because women have POTS and they have orthostatic issues. But it may not show up necessarily as that blood pressure or that heart rate, but it's the headache, it's the dizziness, it's not, and they just don't put it all together. Because it's not happening in the office when they're seeing the provider.
Hey, Dr. Liccardi, Dr. Meinhardt. Carol from Arkansas
Yeah.
has a question.
I have a question. So my daughter has EDS along with lupus, MCAS, intracranial hypertension, POTS. She has it, and she has 9 diagnoses. Kind of, we feel like under the heading of under the heading of EDS. And I'm wondering if the SPECT scans can differentiate between all of these.
So I'll explain why they can't, because they're all happening together in one person at the same time to all of your organs. Right. And so our SPECT scans tell us lots of things about what your brain function is doing, but she has all of these causes contributing to the findings. So I can't look at a finding on a SPECT. Now we can say, when there's connections that we know that there can be links to be made, but you've got, like you said, 9 diagnoses affecting her whole body health. As I just said, your brain is an organ living in
Yeah, gastroparesis is one of those. Yeah.
Right. So there's not going to be looking at, oh, the basal ganglia are high because of this one diagnosis and the other thalamus is high because of this other. No, they're all high together in a cluster as a result of all of these things together. So we would expect to see some substantial SPECT findings happening, but we wouldn't tease out which finding is due to which label because it's not. It's not actually happening that way either.
Okay.
But we do see the basal ganglia often affected by histamine intolerance, by mast cell,
He has
which
that
is
too.
common in EDS and hypermobility. So even if you don't make the criteria for EDS, you could still be hypermobile. I saw a patient today who I actually diagnosed with POTS today in the office doing the physical exam, right? We were doing the physical exam in the office and she met every criteria and the parents were like, oh my gosh. Right. So then you can actually help them, right? You can actually help. I gave her like 3 pages worth of things to consider: food, exercise, therapeutic things that can make her feel normal. She's a 15-year-old kid. I wish
So
you the
from
best of luck.
so from the spec scan, along with the other, the whole holistic approach, there is, you can identify a treatment plan from that.
Yeah.
Yes, ma'am.
Okay, thank you.
Yes. Looking at the chat, we have, could orthostatic hypotension also, yeah, that's part of it.
Yep.
That when you're changing positions, your heart rate goes up and your blood pressure goes down. And so that is what we expect to see, is both of those things happening together usually.
So when your blood pressure changes, it's also about the heart rate. The heart rate there has to be a change of roughly 20 points, right? So you'll see actually the heart rate. So today, for example, it was 78 sitting and it was 103 standing within 2 minutes of it. So, right. And I just did that in the office and I was like, oh, well, she's got this, right? And that is a factual thing. That is factual, right? We didn't make that up. She's got POTS. That's the definition of postural orthostatic or orthostatic hypotension, which happens. And then we go ahead and we do the diagnostic criteria. So yes, 100%.
Then the next one we have Lauren asking, my biggest struggle has been medical trauma and doctors sending patients to us as therapists because they have given up on patients. So I'm seeing all of these things, POTS, MCAS, and other dysautonomia symptoms and refusal of providers to treat. Do you have local cardiologists you refer to? Lisa Marie.
Hey,
So we're here in
Lauren.
Dallas that UT Southwestern has a dysautonomia clinic, right? At their cardiology department.
I'm not aware of the part of
Okay.
Most teaching universities will have but if it's a pediatric or adult, that's something that you need to tease out. But in Virginia, we actually have an adult cardiologist who sees children all the way up. I'm sorry, he's a pediatric cardiologist who sees children all the way up to age 50. He's not an adult, but he sees patients all the way up to age 50. And I can say this to all the providers out there who are, MDs, NPs, PAs, like I'm a cardiovascular trained, right, nurse practitioner. So I understand the heart and blood vessels very well. However, if this is something you're interested in, you could do additional education on this, right? Learn more about it, become a center of excellence, right? For your to be able to diagnose and to treat. That's what we kind of do here, right? We're good at this stuff. So I think what you need to do is find someone locally who can help you. And then, like we said, start with SALT. I'm happy to share the lifestyle things that you can do. It's 3 pages worth of stuff, but there is things that you can do to help with these symptoms for your patients. It just, again, it's not linear, right? It's never a straight line. When you look at health and healing, it's often kind of like that picture of the brain and the heart, right? Where it's kind of all jumbled. And that's okay. Life is messy. Life happens.
Mm-hmm. And we do see patients all over, right?
Mhm.
And people joining us here are from all over. And so this can even start with your local primary care doctor. And we just tell the patient, okay, this is, here's a handout on POTS. And that way they can walk into their primary care doctor with a better understanding of what they're experiencing, how to express that, or explain some of the things that are not just anxiety, but actually the heart rate and the blood pressure changes that they feel and they notice.
We talked about this, and if you look at POTS and dysautonomia, do you feel like it is a manageable thing or a curable thing? So do we get to where, hey, we do all of this and we get us back and we're healthy again and now we're done because we healed? Or this is how you're gonna have to live your life healthier because you have this thing? Does that make sense?
So I never use the word cure.
Okay.
I use the word remission.
Okay.
Because you may get, for example, if it is post-COVID and we get you better, your spike protein goes down, your antibodies decrease, and you get better, I say, wow, that's fantastic, right? High five, we did a great job. But you may get COVID again and have a relapse of this type of illness. And I say and this is where education is so important. And I do think this is where we do a really good job is and this is where you guys come in as therapists and providers, is you educate, right? We educate the patient on what to do. If this were to happen, this is what you're going to do, right? And then you help coach them because they may not be able to get in to see you right away. But again, I use the word remission because again, there may be another virus around the corner that may knock them down a little bit, but then they get I usually say sicker quicker the second time around, but then they bounce back faster.
Do you see any of this? I know we keep connecting it to COVID with clients that haven't had COVID.
Yeah, for sure. Epstein-Barr, HSV, cytomeglia, toxo, mycoplasma, Lyme, Babesia, Bartonella. We see it across the immune system. Like I said, so there's bacteria, virus, parasites. There's different types of immune system relationships that happen because of mold exposure, because of actinomycetes, but also because of physical, emotional, traumatic experiences, real or perceived. I do believe, and the literature supports this statement, that if you have a physical, emotional experience, you may have an immune system dysfunction because it activates a part of the limbic system that increases cortisol. It's always about cortisol in the adrenal glands. Your adrenal glands manage your immune system, right? So if your cortisol can only go up until it can't go up anymore, there's a ceiling to cortisol, right? It can't go up forever. And then when your cortisol goes up because that longhorn is coming after you, immediately you don't need an immune system when you're being chased by a longhorn or when you have a physical emotional experience, right? Cortisol goes up and your immune system automatically goes down. That's physiology, right? That's non-negotiable. That's how the body works until cortisol can't go up anymore. 24/7 stress, phones, computers, work, what have you, illness, and then the adrenal glands and cortisol start to decrease. And so all of a sudden you have that immune system and you have that cortisol response that start to go down. And that's where you start to see that immune dysregulation. You start to see that sympathetic tone where patients will say, I'm wired and tired. I sleep 10 hours, but I'm not rested. I stand up and I want to faint. Ooh, let me hold on to something. I can't walk up a flight of stairs without stopping at the top, right? You'll see people with secretory diarrhea, right? Because again, their adrenals are jacked and they are not getting the response to rest.
It's not normal to take like Imodium 4 times a day for a year. That was an eval that I just did. And I was like, what? No, this should be like, there's a reason that you're doing that. What's going on?
Did you test for that language?
So I don't like the word adrenal fatigue. I think it's a full body fatigue. I don't think that does it justice. Right? I don't think it does it justice. But yeah, you could use, when we're talking so one of the things that I have learned, and again, I teach at Georgetown University. I have been classically trained at multiple universities throughout the United States. I value my education. One of the things that I think make really good educators excel is being able to communicate so the person they're talking to, whether it be a patient, whether it be a student, whether it be another professional, understands. So if traditional medicine understands the word adrenal fatigue, then I'm going to use that term, right? Because they understand that. When I use immune system dysfunction versus long COVID, if they're like, I don't believe in long COVID, well, guess what? It's an immune system dysfunction. And they're like, oh, I got that. I understand what that means, right? So it's how do you communicate so the person sitting in front of you understands? And that changes, right? Depending on whoever's sitting in front of you. It's an individualized conversation. Did I answer your question? Got it. I always ask that too. Did I answer your question?
On the trail sometimes.
Yeah. Yes, ma'am.
As an assessment perspective, should we be asking about COVID experiences
You
on a
can.
regular basis?
Yeah. I think it's
It's kind of a
great
given.
question.
So if
Yeah.
they haven't had COVID, they're going to be the exception to the norm at this point.
Yeah.
So,
And I even have patients who have immune system dysfunction who are in this spot who they'll say to me, well, my husband's sick and man, I just don't, this is one from last week. I just don't feel good, but I tested negative. Well, I mean, the testing I don't think is very good for COVID. The blood work's very good, but the nasal swabs are hit or miss, right? Whether or not they're going to pick it up. But I say, well, you may not just be experiencing the same symptoms as your partner. This may be your symptom, right? Because you can't live in a house and not spread
Most people are just associating COVID with
the cough.
respiratory kind of response and don't realize that the damage that's doing everywhere else. So
Yes, ma'am.
education, I think, is very key.
Absolutely.
and I can't tell you, I couldn't believe the brain fog and the way I relate to patients, because every time I've had COVID, I don't know, 3, I have to work a reduced schedule and I do 2/3 of the patient and it takes me longer to get that done. Even when I'm better and I'm not sick anymore and I'm not coughing and I have no more, like I get, all I'm better. I feel fine. I can work. I'm not contagious. I'm allowed to work. I can't work at the same capacity because my brain fog is just not, and it's like, I just don't work as fast. And I've never worked so slow in my life as when the first time I had COVID, I go, what is this business? And that's where I was like, let's put post-COVID brain fog. It's a legit thing. And patients, really suffer from that and it
Oh, yeah.
affects their work performance.
And yeah, perimenopause on top of that. Or andropause for the men, right? Men have andropause, where their testosterone goes down. You'll see that oftentimes too. So maybe you have a man who's lost his libido or a man who has some complaints. We'll start to see when they're inflamed, men, it's called aromatase. Well, they'll actually take their testosterone and aromatize it to estrogen, and they'll start to have more female complaints, right? They'll start to have some breast, maybe tenderness or chest tenderness. They'll have brain fog. But again, so these are things that we look at. And when I see testosterone low and estrogen high in a man or a woman, right? When I'm kind of like, well, wait a minute, what's going on here? And they have these symptoms, something doesn't match, right? And that's where you're looking at this inflammatory response. But guess what? Your hormones come from your adrenal glands. Your adrenal glands are so important. And another big thing, your adrenal glands have something called the renin-angiotensin-aldosterone system in them, the RAAS system, which, just letting you know, is modulated by vitamin D. Vitamin D is probably one of the most underappreciated tests that we do and one of the most underappreciated vitamins that we talk about. It's actually not a vitamin, it's a hormone. But we see patients all the time. The lady today, she had a D of 20.
Yep.
Yeah.
I've seen some low vitamin Ds. And for
Yeah.
guys, I'm like, you need vitamin D to make testosterone.
Yeah.
And that is my selling point to my,
Vitality.
my 20-something-year-old that doesn't really care about their vitamin D. I'm like, you should care for many reasons that are more important than your low testosterone. But if that's what gets you to take your vitamin D, then that's my selling point, is that you can't make testosterone without vitamin D. So let's take lots of vitamin D because everybody likes high testosterone.
Well, not too high.
Not too high.
Not too high.
But normal. We want Goldilocks.
Yeah. And then one of the things that's really interesting too, which I don't think a lot of people talk about when we start talking about the renin-angiotensin-aldosterone system, which again is that puffiness. Symptoms are going to be puffy when you wake up in the morning. You can't get your rings off, right? Think about that, how the fluid shifts that happen. It's all orthostatic, has to do with the hypotension. It has to do with fluid shifts in the body. Headaches, someone was mentioning about intracranial hypertension. It's a fluid shift that happens in the body that's regulated by the blood vessels, but also the renin-angiotensin-aldosterone system. A big one is also young women who have wonky cycles, regulated by vitamin D, the renin-angiotensin-aldosterone system. You correct the vitamin D, and oftentimes you see, not all the time, but oftentimes you'll see cycles repair, right? Maybe not 100%, but in a young woman, they become more predictable. I like to say the word predictable, right? Is it around the same time, not whenever. Vitamin D is pretty important.
I keep mine on my desk because I'm so bad at taking it.
I know. I get it.
Do you
Yes.
have like a one sheet on the cortisol and the autoimmune? Because we work in coercive control, so
God bless you.
knee deep in the emotional control. My contention is the brain unless you can take it out and put it in the jar, all of these is going to be because your brain is a body fluid, like you guys said. And so we go toe to toe with a lot of times churches who will say, well, he didn't hit her or she didn't hit him or whatever. And it's like, well, that's sweet, but that's not the only thing that happens in abuse. And so I would love one sheet of the physiology of that, complex PTSD where we can say, this is having massive physical ramifications. I know my clients often have autoimmune issues that are horrific. And it's because they've been in abusive relationships for 25, 30 years.
For sure.
And it's shocking when you say those kind of things because it's such common knowledge that your fight or flight response is not a thought in your head. It's a physical reaction in your body, that there's a whole cascade of your adrenal system response when you go into fight or flight mode. It's not just a feeling or emotion or a fear. It's actually a biological response that's designed to save your life, that you were either going to fight the bear or run from the bear. You should run from bears,
Or the longhorn.
or the longhorn, right? But the fight, flight, freeze response is a biological, physiological response, which is well established and very undisputed. Nobody will try to say it's otherwise in the medical field. Like it's kind of a well-established medical fact for decades.
Yeah, 100%. I'd be happy to do that.
Yeah. And
Give me a day or two.
So like, anytime I personally get because I've rather have an ACE before. I actually do it as well. I maybe with their skin do whatever provider I'm about to get into, especially cardiology. Because they're like, well, you need to do this. I'm like, well, that's not always being approved, but thank you for that. And by the way, you understand cases, you understand complex trauma, and you know, mommy, no, you did really bring out 18 heads. So I don't know how it is in the medical community because I'm the one bringing in the research papers and the books and the things to providers very often for my own community, let alone my clients.
Yeah.
Yeah.
Yeah. Dr. Amen just published on that recently, the ACE scores and physiological response. That's something that we're also happy to give you as well. I mean, because again, it's published in a very reputable journal. It's reputable, and it's based on all of our spec scans and all of our patients, right?
Yeah.
So,
and to your point, it's really, there's this massive disconnect in psychiatry and medicine where if you talk to a doctor on the street and you say, hey, what's your fight or flight response? They'll be like, oh yeah, your body reacts to protect you from a threat, right? Like very basic, right? And yet you put them in a clinical setting and exactly what you experience, right? But like they also know that it is a fight or flight response is a biological, right? Like there is a huge disconnect of like applying that knowledge to this situation.
yeah. And some of the things that are really interesting when I look at some of the treatment protocols for these vascular patients, again, they're vascular patients, right? Your brain is made of vasculature, that it's fat and blood vessels, there are drugs that I'm bringing out of the armamentarium from the 1970s, right? Like Midodrine, it's been around forever, right? And it's cheap. But again, we're so used to looking at some of these newer drugs. I'm going for some of the older archaic ones that work really well with these patients if they need it. Right. And then again, you always want to partner with cardiology or neurology or whoever the specialist is that you're working with these individuals. Because again, you can only get better when you communicate and you educate each other. And that's, again, I think that's something that we do really well. And again, it's after hours. It's a lot sometimes, but it's really important. It's what's going to help that patient get better. And that's all that counts.
You also see in the medical world, be more understanding of this. I mean, I think that many of us run into this with on the street medical provider and what have you. So I'm hoping that younger ones graduating, curriculums are changing, you're teaching. Are we seeing a shift into the awareness of this reality of what's really going on?
I would say there's definitely people I think patients are becoming more vocal.
Right.
Which is a positive thing. And I think they're not the younger generation is not necessarily, I know my kids who are 20 and 22 are not accepting the general norm, maybe because they have me as their mom, but also they're not accepting it because they know that they're not going to accept a doctor saying to them, it's all in your head. They're not going to, so they're going to be like, no, it's not.
Yeah.
And they're going to demand something better. I always remember my daughter got sick. My daughter had PANS, right? Pediatric acute onset neuropsychiatric symptoms. She was diagnosed at 6. She's 22 now. And so this was many years ago. And the doctor told me I needed to go home and have a drink with my husband, the neurologist at the very huge, beautiful school one of the schools that I used to work at, right? Said that to me. And I remember being like, And I remember I didn't fight back. I didn't fight back. That was 16, 17 years ago. Right now, I'd be like, what are you talking about?
There's room to trust medical doctors as the.
And I still want you to trust I'm not saying not to, right? But I'm saying that as we prepare our patients to have these conversations, I always say, and I say this to my patients, communicate so the medical provider hears you. When we talk about mold, I sometimes say, don't use the word mold, use the term immune dysfunction. My immune system is not working as well as it could because I have exposures in my house. They'll understand that. The doctors understand that. But the minute you say mold, sometimes they're like, wait a minute. Right. So I always say make it as less threatening if you can. Now that may heighten a PTSD response, right? When you're talking, just ask them to change their verbiage because patients are already jacked up when they're going in to see a new provider sometimes. But because again, I say, I believe you. And that helps them kind of.
And to speak to your question, I think one of the silver linings in all the disaster of COVID is
Research.
is all the research that has come out of it and the spotlight that is being put on this post-COVID, long COVID syndrome, because now all the major hospitals in Texas, here, across you can find long COVID clinics,
Yep.
right? But that opens the door now to think of these post-viral syndromes and not just limited to COVID. But right now we are limited mainly to COVID, but there's a lot that we've known for many years, Lyme disease and Epstein, all these post-viral syndromes that Jackie was talking about, recognizing that there is no conversation around that before. There was no framework for that dialogue. Now there's the common ground that post-COVID, long COVID is in the ICD-10 codes. It's a well-known standard medical care. This is a well-established. Now it took a little bit to get acknowledged and exist. We didn't know what was happening at first, right? But then now it's like, okay, this is widely accepted that long COVID is a real thing, which then allows these similar overlap, right? These inflammatory immune system responses. We're not there yet, but I think it gives us this opportunity then to kind of open up that window into my immune system isn't working right conversations.
And I got to tell you, I actually ask my patients to go back to their doctor when they're 80% better and tell them, what did you do? Well, this is what I did. And I'm feeling so much better now. They can't argue with that because they've seen the patient at their worst and now they're seeing them throughout their recovery process. And that's actually a really good segue into this question. How do you track the changes in the brain when they have holes? How do you know they're healing?
Yes. So exactly. You're right on track, Tiffany. We do repeat scans. And so we do the scan when you come in, and then we can scan you 6 to 12 months later and be able to see that those things do improve. I have a patient we didn't put in the presentation today, but she had 0 psychiatric history in her entire life, professional athlete as her career, highly functioning, great, loving family, everything perfect. She got long COVID and ended up in the psych ER. Like it was terrible long COVID, insomnia induced psychosis, severe anxiety, insomnia, and even mild psychotic symptoms. But from 0 psych history, and I mean, they diagnosed her with long COVID and she came to me and her scans looked exactly, we could have used her in our presentation. Like she matched that. We treated her. She got better. It was night and day. She was back to her usual self, off of all meds, doing totally fantastic. Did a repeat scan. It looked better. The holes filled in. It restored. She didn't need to see me for 3 years. And then actually a few months ago, she had the same thing happen again. It was out of the blue, sudden onset of the exact same symptoms. And it was just like they called us right away. We fit her in. We repeat scanned and her scan looked worse. So we had the first scan that looked bad. The second scan looked great. And then the third scan that we did now with the new problem looked worse than the first scan did the first time. And that speaks to it's worse the second time around.
The sicker quicker.
I saw her today and I emailed Dr. Amen. I'm like, she's 50% better. It was like night and day. Like, so it took a little bit, but pretty quickly, relatively speaking, it's been less than 2 months since she got sick and we started treatment. And she's already like within this weekend, she turned a corner and just suddenly felt way better, so much better back to herself. But we did this the scan this time around, and it was like, hey, this looks just like it did the last time, but see how it got better? We'll get better again. Because she also was like, I'll never get better. I can't live like this, and having lots of suicidal thoughts and just terrible, terrible sudden onset. And again, she's seeing Dr. Cornish, one of our other integrative medicine doctors, and she's taking ivermectin and Valtrex, antiviral, whatever ivermectin falls into malaria, all of
Anti-malarial,
malarial, but
antiparasitic.
everything. But yeah, her blood work came back that we've got some infections going on. And so we did all the, medical testing,
All the stuff.
all the stuff. We tested everything. But we're waiting for the Lyme disease to come back still from IGeneX. But yeah, so we started treating it both with psychiatric medications and with antimicrobials, and she got better, and she's not 100%, but we're going to get there. And yes, we use the scans and they're really helpful. We can repeat them and track the progress.
For hope and individualized treatment.
Yeah.
Excuse me. So if the patient asks me if SPECT scans can detect neuroinflammation, I tell them yes.
The answer is yes.
Okay, and it's overactivation on the activity scan.
Yeah, so it looks like those really red overinflamed scans.
Okay.
Yeah, that's the neuroinflammation response.
I have another question.
Patchy diffuse uptake is what you'll read on the report.
Okay, got it. What about Zoloft? Does that worsen POTS? I have a lot of patients that tell me, okay, we gotta get off this Zoloft.
Depends on the type of POTS that you have. We did not get into all the nuances of the hypovolemic
Versus dysautonomic versus
adrenergic.
adrenergic.
So if you have there is a subtype of POTS that's dysadrenergic, and that Zoloft does affect that, and that is established in the literature and the research. And so not all POTS, but one subtype, Zoloft makes it worse.
Is it specifically Zoloft or SSRI?
SSRIs.
Okay.
Yeah.
But so that's the fear too, is some people will say they're resistant or they're refractory patients, right? When they're not, right? So that's again, you don't want to label these people as refractory or non-responsive. That's why it's always that next step, putting it all together. And look how smart you are. Yes, sir.
We have missed, are there genetic tests that you do too, as part of the diagnostic process?
For POTS, we don't necessarily do them. I don't necessarily do them because for insurance purposes, they may not be covered by insurance if I order them versus a cardiologist. So I always refer to cardiology, especially in patients who have severe heart rate changes and blood pressure changes. I think it's prudent, right? And medically necessary. They oftentimes will do that testing.
Because a person could have that predisposition, but then get an inflammatory process or a trauma, and then you see the symptoms.
Just depends. Yeah, but it's again, I try to be mindful of insurance for some of those testing because that can be expensive if it's not covered.
And how do you ferret out all the different varieties of POTS?
Again, when we start talking about the more classic type, not classics, but the more nuanced types of dysautonomia, I think, again, that's where you're going to want some advanced testing. Like I don't order tilt table tests because I don't have hospital privileges, right? So I can't, that's usually done in a hospitalized setting, not inpatient, but a hospital setting, outpatient setting. That's why we send them to the cardiologist to differentiate, because again, you treat each one slightly different. Some of them you treat all the same, like there's some certain things that are some you do for all of them, but then there are nuances to each type. And again, like we were talking about, if there is a medication that may not be the best type for a neuroadrenergic, then we want to make sure that we can say this is what it is, and then educate the patient. So if she goes to somebody else, she knows to say, oh, whoa, whoa, I don't need an SSRI, I need something else.
Do we have any other questions online?
Thank
Any
you.
other thoughts? Yeah.
Great.
Okay, you guys,
Thank you guys for awesome.
Hey, you guys just got 30 minutes of your time back. That is always a blessing. So thank you so much for joining us, and hopefully we will see some of you guys December 4th at our progressive holiday dinner. We're doing something a little bit different, where we're not going to be in the training room for the holiday party. We're so excited about that. We are going to do a progressive dinner where you go from doctor's office to doctor's office. You'll hang out with Dr. Licciardi for some hors d'oeuvres. You'll hang out with Dr. Sangra for some desserts. You'll hang out with Dr. Kansara for some drinks, non-alcoholic, of course. But we'll do something a little bit different. So it'll be a lot of fun, and hopefully we'll see you guys there. Have a great night, you guys.